Good evening everyone, and welcome to our first of the GP Evenings webinar series. My name is Jeff Buckley. I am the Director of Insight, which is the Alcohol and Drug Training and Education Workforce Development Unit here in Queensland Health, and we've been very pleased to be helping out with this series of workshops for GPs and medics across Queensland. Just if you haven't already done so, could you please fill out the pre-evaluation in that yellow box, and if you join later, the link is also in the text box to the side. Before I go too much further, I'd just like to acknowledge the traditional owners on the land of which we're gathered today and pay respects to elders past, present and emerging, and extend that to any one of you out there who may be of Aboriginal or Torres Strait Islander background. So this particular webinar this evening, the first one for the series, is being kicked off by our very own Dr. Mark Daglish. They have been organised in a partnership between Insight, QNADA and a series of PHNs across the state, which are on the screen now. So Western Queensland, Central Queensland, Wide Bayou, Sunshine Coast, Northern Queensland and Darling Downs and West Moreton. And this activity is supported by funding through the Australian Government under the PHN program. Dr. Mark Daglish is the Director of Addiction Psychiatry at the Royal Brisbane Women's Hospital here, where he is the Clinical Director of the statewide Inpatient Alcohol and Drug Service, affectionately known as HADS, which he'll talk to you a little bit about tonight, I'm sure. If you're having any problems, please call us on 3837 5655. We have someone on the phone to help you with any tech issues, or write any questions in that dialogue box to the bottom left of your screen, and you can, we'll have a tech support person provide you with advice there. But without any further delay, I'll introduce Dr. Mark Daglish to talk about the clinical management of substance withdrawal states and insight for support for GPs. Thank you, Mark.
Right, thank you, and hello everyone. I'm going to try and pitch this at the level, I do a few talks with GPs occasionally, and I'm going to try and pitch this at that kind of level where I'm expecting some medical knowledge, but not necessarily expert or widespread experience with alcohol and drug issues. And I'm also kind of pitching it at I do a lot of work within the hospital in a consultation liaison space, so seeing people in medical and surgical wards with comorbid drug and alcohol issues. And the kind of advice I frequently find myself giving to multiple doctors in that setting is the kind of level I'm trying to pitch this at. So hopefully that's about right for you. But if I'm skipping things that you want more detail, or I hope it's not going to be patronising, but if it is, please sort of flag and let me know. What I'm going to try and talk about in sequence is some brief generic stuff about withdrawal and some of the commonalities, and then I will specifically talk through alcohol, opioids and amphetamines, predominantly methamphetamine because that's what we see. Benzodiazepines is going to be covered in a separate one. I think it's number 3 in the series. And we will be doing, I think number 2 in the series is a complex cases based presentation. So some of that sort of multiple polysubstance and so on, we can perhaps hold over to those, and I'll talk more about the specific withdrawal states themselves this evening. Most of what I'm talking about should be compatible with the withdrawal guidelines. Those are available online, and I would encourage you that if you're looking for detailed information, it's in the main body of that, and then there are in the appendices things like withdrawal scales and so on that are sort of pick and mix and sort of quicker and easier accessible withdrawal scales and things of that nature. Okay. I think the first thing I want to stress about withdrawal is a lot of people come to us looking for withdrawal as though, this is going to be cure. I just need to get off it and then I'll be fine. And it's not. That's not what withdrawal is about. When we talk about people coming into my inpatient unit, we talk to them about, we are simply the first step on your journey into what's actually coming next, which is where the real treatment lies. So withdrawal or detox, as it's colloquially known, it's not cure. People are not going to be fixed in a week. It's not that simple. And similarly, withdrawal is not rehab. It's not residential rehab, it's not prolonged outpatient rehab, it's not counselling. It is that process of getting somebody from recurrent, repeated, possibly continual use and intoxication, hopefully safely, to ideally abstinence, but that might be a goal that's not on their agenda. It may be about reduced use, or it may be about stabilised use. So it's about that transition period, that first step, and that's what I'm going to talk about this evening. There are, I put DSM-5 and ICD-11 up here, but there are lots of different, there's still ICD-10 and DSM-4 for folk out there. But what I want to pull out from the classifications and the definitions is that these are substance-specific syndromes. And one of the things we're often faced with when we go out into the medical or surgical wards is somebody might be coming off multiple substances, or they might be coming off opioids and benzos, and we find an alcohol withdrawal scale in the notes. And you're sort of asking the nurses, why are you doing an alcohol withdrawal scale? It's like, well, they're in withdrawal. It's like, well, yeah, but they're not an alcohol withdrawal. So it is substance specific. There are some commonalities in the neurobiology of all the withdrawal states, from nicotine to methamphetamine to opioids to opioids and benzos, but they're substance specific. Managing it, like most things in medicine, the management really comes down to good assessment. The more you know that's going on, the more you can plan for, the more you can worry about. The things that catch you out are the things that you didn't know about, and that's when it tends to go wrong. Obviously there's things like quantities, how much have you been drinking, how long have you been drinking at this level, but also how long has alcohol been a problem for you. Or and oftentimes people will tell you one of those answers, but not both. So you ask somebody, how much Valium are you taking, and they'll tell you, well, 100 milligrams a day, and then you find out, well, is that the 100 milligrams they've been taking for the last fortnight, or no, that was what they were taking up until about a month ago, and then their supply ran out, and that's what brought them into treatment, and then so they've only been going on for about 10 or 20 mgs. So getting that quantity accurately assessed, and the pattern is also important, because somebody who's drinking 50 units of standard drinks a week spread over 7 nights is going to have a very different pattern of withdrawals from somebody who's drinking 50 standard drinks but on 2 nights a week. So the pattern is also important. Sometimes useful questions about what's the most you would have in a session, and what's the minimum you can get away with before you're feeling like you're hanging out or you're in withdrawal, or what's the minimum. And I often find at this part of the history taking, there's an elaborate poker game going on where I'm sort of third order level of mind. How much of what you're telling me is what you think I need to hear in order to get me to do what you think you need? Which takes a bit of unpicking. Because oftentimes people are worried, oh, you're not going to give me enough, therefore I need to tell you I'm using more. Or it might be, oh, well, I don't want to seem too bad, so I might just downplay, or I'm not quite sure how you're going to react, so I'm going to dip my toe in the water and tell you about this, see how you react, and then decide whether or not I'm going to tell you the other piece of information. So it's really quite important just to try and unpick, and I often find it useful to ask people the same questions in different ways. Much as you would in the rest of medicine. So I might ask people, how much are you drinking in a day? I might ask how much you're buying, how much is that costing you, what time of day do you start, what time of day do you stop, and see if all of those answers match up, because they don't always match up, and sometimes that's memory deficit, which is an important clue for other things that might be going on, and sometimes it's, well, there's more to this truth than meets the eye. And also, like most things in medicine, the best predictor of what's likely to happen is what happened last time. So finding out about previous periods of abstinence, what was it like during that, or even just cutting down, what happened? Did you have any withdrawals? Did you not? How bad were they? Were you on treatment at the time? One of the places I worked previously where we didn't have an inpatient admission unit for withdrawals, our question was, okay, so you've had a withdrawal seizure, but were you on Valium at the time? And that was our sort of threshold for whether or not we were going to go looking for a medical bed. So how severe the withdrawals have been and whether that was in a treated or untreated context is useful. And how severe, and were there any complications, and are there other things going on that might make this more difficult or more dangerous? So those kind of things are important to cover across the board. And it might also give you clues about whether there's secondary substances that you might need to bear in mind. Okay, you have to start with alcohol. It's top of the list when it comes to damage that we see. And I mean, the unit where I work, we admit 1,000 to 1,200 people a year for mostly for withdrawal management, and 60% of that is alcohol. About another 20% is alcohol and something else. Alcohol and benzos, alcohol and opiates, that kind of thing. And that's partly representative of just what drugs are people using, and it's also partly represented by which are the most dangerous withdrawal syndromes that are likely to require an inpatient treatment episode. And I think if you're mentioning alcohol, you have to start at the top and work down. So, how much, how often, how long? What were those withdrawals like? As I say, things like particularly seizure history, but also just the severity. The other thing to bear in mind is the more times you do it, the worse it tends to get. There's a kindling effect, and I do mean that specifically in the same sense of kindling effects with neuronal wind-up phenomena, like with seizures, that you do tend to get an increase in the severity of withdrawals, and it probably is also glutamate mediated, like the kindling effect that you see in other neurological conditions. So it's one of the reasons why we don't like to keep doing that revolving door of admission, withdrawal, relapse, admission, withdrawal, relapse, because it probably is actually aggravating and augmenting the damage that's being done to the brain by the withdrawal syndrome. So it's not just that they've been drinking for longer and therefore things have got worse. There does seem to be a pattern of worsening withdrawals. And you want to know what else is going on, particularly with alcohol, because the withdrawal syndrome is challenging on the body. You also want to know what else is going on, and also because alcohol is such a widespread toxin, you've got to look for those other alcohol-associated comorbidities. So our routine screen on admission to the ward has that full sort of biochemical screen, full blood count, looking for, we see signs of pancytopenia from the bone marrow suppression. We see the low platelets from the liver disease and the back pressure from the cirrhosis. We see the chronic gastritis and malnutrition giving them anemia and maybe sort of low-grade continual GI bleed. So that anemia is quite common. Malnutrition is so common in this group. That biochemical screen for electrolyte disturbances. We're often seeing people with mildly low sodiums, low potassium, magnesium, phosphate, and all of these things are potentially markers of we might be in for a tricky withdrawal episode here. So we're certainly in the ward quite aggressive in terms of supplementing those. Lipase, of course, we know the association between pancreatitis and alcohol, and a coag screen. Because liver and coagulation is important, and certainly anybody with esophageal varices and poor coagulation is got to be somebody that you're going to watch like a hawk. And we're really screening for those things like gastritis, alcoholic hepatitis and cirrhosis, pancreatitis, malnutrition, and in fact increasingly we've recognised that a lot of the biochemical changes that we see at the severe end of the spectrum start to look like refeeding syndrome. Which I've seen, one of those things that we really woke up to after a lunchtime conversation with the director of the Eating Disorders Service, and realised that we were seeing a lot of the same biochemical abnormalities that they were seeing as they were starting to refeed their patients with anorexia. So those are the sort of things that we're screening for all the time. And obviously most of our patient population are smokers as well, so you've got all the smoking related diseases to screen for as well. this is what we're expecting to see when it comes to alcohol withdrawal. The simple withdrawal, relatively straightforward to manage. You're trying to treat that as it's emerging with a view to hopefully preventing it progressing on to that more complex withdrawal syndrome. Generally the ones that give us the most difficulty in the inpatient unit are folk who are coming in having already had their first withdrawal seizure, and that's their reason for coming to hospital. They've decided for whatever reason to stop drinking on their own, or some circumstances has occurred that meant that they couldn't drink, and then the withdrawals are getting significant, and they come in to hospital when they have their first seizure, and then we're playing catch up, and it's really quite difficult. And then we know we're in for a difficult admission to try and control the symptoms. So you're trying to get that treatment in early, trying to titrate it against the expected severity of withdrawals, and then tweaking it based on the feedback to try and match this kind of pattern. And it's that early nausea, tremor, sweats, anxiety that people recognise as being part of the simple alcohol withdrawal. And keeping an eye out for early warning signs that there may be that complex withdrawal syndrome with the confusion, disorientation, hallucinations, and generally the delusions tend to be scary. So that paranoia and that sign that the full-blown delirium tremens is emerging. And of course some of that may well overlap with Wernicke-Korsakoff. So we're looking for those early signs, and then we're titrating our treatment against these kind of symptoms. The sweating, the shaking, the nausea. A lot of people are very good at nurse-induced tremor, we find in the ward. Again, that comes back to what do I need to do in order to get the treatment I think I need. So we're quite good at spotting nurse-induced tremor. In fact, one of the things that we will do is hands out, and you're looking at that tremor, and then I get people to stick their tongue out at the same time. Because it's quite difficult to keep the tremor going and stick the tongue out at the same time. And I don't think I've been fooled yet with somebody able to fake the tongue tremor. And certainly when you see that fasciculation in the tongue, that's usually a sign that they've got some good going alcohol withdrawals. So that's definitely, and again, you're assessing all the other things that you'd normally assessing when you're looking at somebody's tongue. Signs of B12 deficiency, dehydration, and poor dentition, and all these other things that tend to go along with, or might be going along with, alcohol withdrawal. The nausea we see. One of the things that we often see is that the nurses, have a sort of reflex, nausea, vomiting. You've got to go for the Stemetil. You've got to go for the Dimaxilon. Actually, those centrally acting anti-nausea medications, they're great for central nausea, but a lot of this nausea is gastritis. And Maxilon's not going to do anything for gastritis. So when I come to talk about treatment, I'll talk about those kind of things. And again, generally speaking, that poor appetite, anorexia, very common. And across the board, pretty much any withdrawal sign, usually when they start feeling hungry, you turned a corner and things are starting to improve. Insomnia, though, is a real challenge for most of our groups, and it's often one of the things that triggers relapse, tends to drag on for ages, very challenging to manage, and difficult to manage without starting another dependence. Most hypnotics are going to be drugs that potentially have abuse potential or dependence potential, so they're tricky. The muscle cramps we definitely see, the mood disturbance, particularly the first few days, that lability of mood. It just bounces up and down. You've got cheerful 1 minute, floods of tears the next. And it can be very easy to sort of rush and think, we've got a mood disorder, we've got depression here. But actually what you're seeing for the first few days is almost just that labile mood from alcohol withdrawal. And keep an eye out for those perceptual disturbances. Often it's little black dots that then, combine with formication, that feeling of things on the skin. You combine that with black dots, and the next thing you know, you've got an insect infestation, and people are worried about the spiders and the ants and that. So it can be an early warning sign to watch that DTs are on the way. And it's just overactive neurons, of course. The seizures are a worry. Obviously, they're not ideal in any circumstance. At least in the ward we've got 24-hour nursing cover, but this is one of the things that we worry about, particularly for community withdrawals, particularly if people are living on their own. It's difficult to get proper prevalence. They tend to happen early. And I've certainly seen people at the severe end of the spectrum who are normally running with a sort of blood alcohol of 0.1 to 0.2, having a withdrawal seizure before they're blowing zero. In fact, before they're even sober enough to drive. They're still blowing more than 0.05 and yet they still have a withdrawal seizure. So you're looking for reductions in alcohol as being potentially the trigger there, not necessarily abstinence. And again, like most things in medicine, the best predictor is, has it happened before, or have they got something else going on that's annoying the brain? And these are the sort of things that we tend to see. So, electrolyte disturbances, previous head injury, or a current head injury, even more so. And then you're often in that tricky situation where somebody will come in with alcohol withdrawal and a head injury and an altered conscious level, and you're trying to think, how on earth am I going to treat their alcohol withdrawals without making the neurologist's job impossible to work out, because we're then adding in medications for alcohol withdrawal like diazepam, that potentially is going to cloud their consciousness, and the neurologists are trying to work out how much of that clouded consciousness is alcohol withdrawal, how much of it is benzo intoxication to treat the alcohol withdrawal, and how much is potential head injury. And that's a very difficult tightrope to walk. Obviously, anybody in that boat, we're looking for managing them in hospital, not as a GP outpatient, but yeah, that's definitely the kind of thing that we worry about. Similarly, the DTs, the best predictor is, has it happened before? And malnutrition, I think, here is also key. And I think it's not that often that we would see delirium tremens on its own. Predominantly what we will see is delirium where alcohol withdrawal is one of the main contributory factors. There's often something else going on. It might be Wernicke's, which I'll talk about in a second, but it might be some other, so there's a sepsis going on, there is some other metabolic disturbance, there's a refeeding syndrome, so many different things combining. Chest infections in the older group with COPD from a lifetime combination of alcohol and tobacco, difficult to manage, and you're looking for that fluctuating conscious level. And again, that tends to be the pattern. You can say this is what tends to happen in hospital, of course, is the nurses come to the doctors and say, oh, this patient's confused. We go and talk to them and they're absolutely fine. You're making a fuss about nothing. And of course, it's that fluctuating conscious level that's characteristic of delirium. But this can be a very tricky group to manage. Definitely, if you're seeing signs of this, that's something that you want to be sending our way, not trying to manage outside a hospital. And this is where the death rate is associated with. Untreated DTs, they reckon, has about a 20% death rate. So what does the treatment look like? Well, use a withdrawal scale, and I'll talk about those specifically in a minute. But the withdrawal scales are useful for monitoring alcohol withdrawal. Daily breath alcohol, and enough diazepam. And that's a difficult concept. What is enough? Because you're obviously not wanting to give too much, but you don't want to give too little either. And we have a recurrent debate with ourselves about how best to do this. In our inpatient unit, where we have nurses that are doing, potentially they'll do 5 or 6 concurrent alcohol withdrawal patients at a time, at any given time. So they're doing it day in, day out. We've got good inter-rater reliability with alcohol withdrawals. They know what they're looking for. We can just let the nurses titrate the diazepam against with the withdrawals. And particularly in this uncomplicated group. Our experience is if you try and do that anywhere else, like a general medical ward, a general surgical ward, the inter-rater reliability in inexperienced nurses of measuring alcohol withdrawals means that you get doses of diazepam that are all over the place. The other common problem that we see is we'll get called to see somebody 2 weeks into their admission, they're still on 40 or 50 mgs of Valium a day for their alcohol withdrawal, and now we've got, they've just transferred drugs, and we've got to wean them off their iatrogenic benzodiazepines. So that tends to be one area that we see, is they just kept on high doses. That's what they needed on day one, and that's just what gets continued for the rest of their 2-week admission. Or the other thing that we'll see is they may get 5 milligrams of diazepam in the emergency department, and that's it. And then we get asked to see them at day 3 to try and control the DTs. So we're trying to do something that is tapered, but flexible enough that people aren't over sedated, but they're also not underdosing either. So the regime that I've suggested here is what we tend to use in the general medical and surgical wards, and that's based around the idea of it should be enough for most people, shouldn't be too much for too many, and the advice you're giving the significant other that's hopefully accompanied them to the appointment, that you can give the instructions to that they will remember, is, don't wake them up to give it. And if they're rattling and they need a bit more and they're still shaky, then they might need a bit more. And we're aiming for 0 at the end of the week. And that kind of regime gives you an idea of where you're at. Obviously, diazepam goes out through the liver. So if it's significantly compromised, we tend to switch. And the other thing is it tends to accumulate if your liver's not working terribly well. You can get away with oxazepam in more damaged liver disease because it doesn't tend to accumulate to the same degree. So we will use oxazepam in people that are potentially compromised liver, and about a 3-to-1 ratio. But that's an example regime. It's not meant as hard and fast, but it gives you a starting point to then look, okay, am I expecting more or worse, more or less than average? Now, the alcohol withdrawal scales, we use the alcohol withdrawal scale in my ward, but there's also the CWA-AR. They're both really good at measuring change when the same person's applying it, but they are not a diagnostic tool. And if you start to use them as a diagnostic tool, we will see this, where people's sepsis, because the AWS includes things like temperature and pulse. If somebody's septic, those will both go up. And you do not want to be trying to treat sepsis with diazepam any more than you want to be treating alcohol withdrawal with an antibiotic. So they're not diagnostic tools. But with a bit of practice, the inter-rater reliability gets very good, and they're really good for measuring change over time in somebody who just has alcohol withdrawal. And they can be very quick and easy to run through. Now, the other thing you want to make sure you're catching is Wernicke-Korsakoff. This is one that we labour again and again, but we know from data published from PA Hospital a few years ago that actually in medical wards this tends to be underdiagnosed and undertreated. It must be even harder in the community. So we specifically work on the principle of thiamine is safe, relatively cheap, and we aim to give too much to everybody so that nobody gets too little. And that's our rule of thumb, because otherwise you end up with brain damage. So we know that most people don't have that classic triad that we all learn at medical school of nystagmus or ophthalmoplegia, ataxia and confusion. In fact, only about 10% have all of that. Most folk, it's the confusion. So yeah, you've definitely got to treat it. And what do? Well, we just jab everybody with thiamine on admission, 100 mg IM. We're able to do that. We're an inpatient unit. We've got it in stock. It's very quick, easy to do. I've worked in previous community units where we weren't allowed to do that because of the risk of anaphylaxis. The risk of anaphylaxis is way, way lower than the risk of Wernicke-Korsakoff. So what we do is based on 100 mg vial size. Certainly people would argue that you could go bigger than that, and I think that's probably the minimum you'd want to be giving. But I know that we see the severe end of the spectrum where I work. And as soon as you start to suspect Wernicke's, I'm hoping that if they're that badly into withdrawal, you're going to send them towards hospital. But also, there's no harm in getting that first shot of thiamine into them. The sooner the better. And those are the kind of regimes that we look at. And I put a few other regimes in there based around the thiamine sizes of vials that are available in Australia. We have thiamine 100 mg, we have thiamine 300 mg, we have B-dose Fort. Don't bother with B-dose. That's a tiny dose of thiamine. The B-dose Fort has a decent dose of thiamine in it, and B6 as well. And certainly the PA hospital uses Pabrinex. So as I was saying, yeah, and the PA hospital uses Pabrinex. I hope the last thing that you heard was me talking about B-dose Fort being worth looking at as an alternative, but B-dose isn't. Pabrinex is also used at the PA hospital, but is actually not TGA approved in Australia. It's just widely used elsewhere in the world. And the other thing that we do is everybody that has an episode of alcohol withdrawal, we just put everybody on oral thiamine, 100 milligrams 3 times a day, when we advise them to keep taking that until they've been sober for a month, with the implication deliberately there that if you relapse, you also keep taking the thiamine. And we also give a broad spectrum multivitamin as well, covering things like zinc, because we think that that's also likely to be involved in the micronutrient malnutrition that you see widespread in alcohol. Useful things for managing the concomitant symptoms of alcohol withdrawal. Antacids, I think, you know, certainly in the ward we've been on a crusade to get these used more. They're quicker acting than a proton pump inhibitor when you've got alcoholic gastritis, and they're often really effective for that initial nausea on day one that we see. You know, we use Gastrogel in the ward, but any antacid would do. And then moving on to metoclopramide. And actually we've started to use olanzapine as our go-to centrally acting antiemetic, because it's so good on the, you know, as a 5-HT3 antagonist. For the dyspepsia, again, the usual meds. When it comes to electrolytes, we've got a very low threshold for topping up, particularly magnesium. We do this all orally, magnesium, phosphate and potassium as required based on the blood results. But magnesium in particular being so safe, orally we tend to top that up to begin with and then stop doing that if it's not needed, rather than wait for the blood results to come back. Because we know, you know, there's not brilliant evidence, and certainly not Cochrane database level evidence of magnesium helping in alcohol withdrawal, but it makes sense pharmacologically. Magnesium has a binding site in the glutamate receptor, which we know is overactive in alcohol withdrawal. We also know a lot of our patients are magnesium deplete, partly because they're on a PPI and partly because they're malnourished. So on the basis of something that's unlikely to do harm, may help, we tend to top that one up first. The phosphate and potassium, we tend to wait and see what the blood results are like. The insomnia I mentioned, we tend to use cyproheptadine, periactin, or low doses of mirtazapine, and it's a better hypnotic at low doses than high doses. As you put the dose up, you get a stronger antidepressant effect, but that can actually become alerting at high doses, so it ceases to be as good a hypnotic. And we do, for people who are disturbed, particularly if they're starting to get, you know, a little bit paranoid and persecutory delusions, you know, we quite like a little bit of olanzapine at night to help with both the nausea and the agitation and the sleep. One really good piece of advice, once they're through that acute withdrawal, if they've got prolonged insomnia, when I previously worked in the sleep clinic, what we used to say to people is, if you have 2 bad nights in a row, take something on the 3rd. Because most people can get by on 1 decent night's sleep out of 3, and if you know you're going to get that, you stop worrying about it as much, and then you don't get people's worry about insomnia keeping them awake at night. So, and it tends to be sustainable at that sort of level. You're not going to get that tolerance effect developing. So, that, you know, I think that can be useful. And just warn people that insomnia is going to be an issue. So maybe it's time to get a boring book. Don't sit up all night smoking, drinking coffee and watching the telly, because then you definitely won't sleep. And all the usual sleep hygiene advice that you give people. Things I do want you to worry about. Red flags, obviously if they've got that history of complicated withdrawals, seizures, DTs, particularly if that's been when on treatment, then please send them our way. You know, significant comorbidities to watch out for. Suicidal ideation, we find that often lifts quite quickly in with withdrawal, because often a lot of that suicidal ideation is, I've failed again, I'm never going to get better. The poor impulse control of intoxication, that labile mood in the first couple of days. Usually we're looking for that mood to turn a corner about day 3. And if it doesn't, then we might look and see, okay, do we have to do something more specific? But it is something to watch out for because of that association between alcohol, low mood, and suicidal ideation. Obviously, any of those other red flags like hallucinations, we definitely want to be seeing people. If their liver's badly deranged, they may need treatment for that elsewhere. The other thing, of course, is have they got a safe place to stop drinking? We do look after a significant homeless population, or if they're in a drinking environment, they may not necessarily need a hospital bed for withdrawal, but they might, it might be an NGO withdrawal unit. So, some of the NGOs run withdrawal units with lower levels of medication and medical cover. They don't have, the backing of a 960 bed hospital behind them with an ICU and a crash team. But, people don't necessarily need that. They need an environment in which it's safe to come off alcohol with little to no medical treatment. But, or if you're going to try and do this as an outpatient, can they actually get to the treatment daily, which can be tricky. And if they've tried that outpatient method and it's failed, and obviously there's that feedback loop. So if things are not going as you expect, that might be grounds for sending them our way, or getting local AODs to have a look at them. Right, now because of the technical difficulties, I'm going to have to race through these a little faster. But I'll start with opioid withdrawals now. Again, it's the same kind of thing. So the assessment, absolutely the same as it would be for alcohol. How much, how long, what's it like when you stop? Less dangerous, but pretty unpleasant to go through. You're looking for that acute phase and then that prolonged phase, and that noradrenergic storm. So that's the things in blue that with the asterisks, those are the sort of noradrenergic storm. But there's a whole heap of stuff. The big pupils, the vomiting, the diarrhea, all that autonomic over-arousal. Again, the loss of appetite, nausea, vomiting. Once people are hungry, that's often a sign that they've turned the corner. But that dysphoria, insomnia, restlessness, those are the things that are often really driving people. I've had a bunch of folks say, oh, look, yeah, you just feel crook for a couple of weeks, but that's fine, you can get through it. But it's the dysphoria and I can't sleep and I just can't get comfortable anywhere. And the craving, that tends to be the thing that really drives. The psychological withdrawals are often what drives people's relapse. Physical withdrawals are unpleasant, but the psychological stuff tends to be what people can't tolerate. This is the sort of pattern, these are schematics, this is not an accurate depiction, but this is a sort of schematic of the kind of withdrawals that you'd expect. So coming off short-acting opioids, you get that rapid onset, peaks at about day 2, day 3, and things are going well by about day 5, and it's mostly over by day 10. You've got the long-acting opioids, mainly the ones that we use for opioid maintenance treatment. So methadone, it's a slower onset. It's not as high a peak, but the area under the curve is probably the same. That protracted, and people will talk about, oh, methadone, it has to come out of your bones. That's not what's actually happening, but I can see why it feels that way. That aching and that protracted withdrawals that can drag on for 10 to 14 days. It is when comparing and contrasting with patients, I often talk about, are you the sort of person that likes to rip the band-aid off, or do you peel it off slowly? And that's kind of the comparison. Buprenorphine, again, it's another long-acting drug, but it does seem to be a lot milder in terms of its withdrawals. Obviously, there are the subjective components, and also I find, to some extent, people who are ready and know why they're going through this, they have a clear goal, it doesn't tend to feel as bad. Even if objectively it looks just as bad, it doesn't seem to feel as bad. And similarly, some people where the objective withdrawals don't look too bad, but subjective, they really feel like they're suffering. The other thing you'll notice is that none of these curves get down to 0. And there's that protracted withdrawal phase that often drags on for 3 to 6 months of just that, intermittent grumbling still in the background, anhedonia, using dreams and waking up feeling like you're hanging out, and just not quite feeling back to baseline. That can drag on for months. The other thing also is that we really don't know quite what to pitch with short-acting drugs in a slow-release preparation, because you get a different curve again there. OxyContin is not a long-acting drug. It's a short-acting drug in a slow-release preparation, which gives you a whole different, kinetic profile again. So just trying to bear in mind that there is that difference as well. There are withdrawal scales that are in that withdrawal guideline that I talked about. There are objective ones, subjective ones. There's the cows as well. Any of them are reasonable. Any of them are valid. Just be aware of what you're measuring, and the subjective ones may not match the objective. And the extent to which that matters is going to depend on context. So if you're worried about accidentally overdosing somebody on a replacement preparation, particularly like, say for example like methadone, then the objective withdrawal scale is going to be important, because you're looking for signs of measurable intoxication and withdrawal. On the other hand, if you're thinking, well, we're actually not going to be using medications that are dangerous in excess, then the subjective is a measure of their distress and may actually be better a guide to, do we need to put the dose up? Do we need to manage this a bit more aggressively? So horses for courses, I guess, is what I'm saying. There are various symptomatic treatments that you can use, a sort of pick and mix bag for the various different withdrawal symptoms. That has the advantage that you don't have to use opioids, so there's the reduced abuse potential of the medications that you're using. People aren't going to potentially divert, people are not going to divert loperamide. Well, no, some people will abuse loperamide in doses of a sort of 100 mg and upwards, but that's a very small niche market. You don't need the regulatory approvals to use these medications either. And they're good if you're not sure how severe the withdrawals are going to be or the level of dependence. And if somebody's going to have mild withdrawals, then these are often very useful and all that's required. And it avoids that risk of accidentally overdosing somebody on an opioid where you've miscalculated their sort of equivalent tolerance. You do have to be careful with clonidine though. Those of you who are familiar with using it previously as an antihypertensive will know it does have a habit of dropping your blood pressure and slowing your heart rate. And that tends to be worse if you're dehydrated, which of course if you've got nausea, vomiting and diarrhea, you're likely to be dehydrated. So getting dizzy and falling over is a definite problem with the clonidine that limits the doses that you can use in the community. It limits the doses we can use in the ward, and that's with nursing cover 24/7. But nevertheless, it can be a useful medication. And then the other things are pretty much what you'd expect for symptomatic treatment. This is the kind of regime that we use in the inpatient unit, based around these sort of doses and medications. Obviously the ibuprofen, you've got the caveat of making sure there's no gastric symptoms, that they're not got dyspepsia and so forth. And the diazepam, again, you're looking for a short course. You do not want to be just switching from one drug of dependence to another, because you're going to hear about benzodiazepine withdrawals in the third seminar, and they are certainly a challenge to manage. But short courses and trying to match that clonidine and diazepam regime to the expected time pattern of the opioid withdrawals is the key here, so that the hypertension from the withdrawal is offsetting the hypotension from the clonidine. Alternatively, you can look at using buprenorphine to manage their opiate withdrawals, and there are pros and cons to this. The cons obviously being that you need the MRQ approval for this. You can get that approval by being trained as a prescriber, but MRQ is willing to negotiate for individual approvals for individual cases, particularly if you're working in conjunction with a local AOD service with some advice, and looking at small doses of Suboxone, then it's not unreasonable, and particularly if you're a long way from an AOD service, Again, that might be worth having a discussion with local, a telephone discussion with an addiction specialist like myself, and then looking at doing something with small doses of Suboxone in the community. You just have to watch out for giving it too soon. Precipitated withdrawals, it has a high affinity for the receptor. If you've got a full opioid agonist on board, it will push it out of your system and give you precipitated withdrawals. So if people have had precipitated withdrawals before, they will tell you they don't want their Suboxone yet. They want to wait until they're in enough withdrawal. But for the first time, often persuading people just no, wait it out, wait it out, wait it out till you've got some significant withdrawals, and then we'll come in with the Suboxone. That's the way to go, and you need to wait and then give them that small test dose, see how they go, and if and you should be good to go then. You do get better symptom control. You often don't then need any of those PRN symptomatic medications, and generally that tends to keep people in treatment. And certainly we found that since the switch to buprenorphine as our preferred opioid withdrawal medication, early discharge rates are much lower. You can top up with those symptomatic treatments if you need, and sometimes they're useful for that initial gap to just coax them through until they're ready for that first dose of Suboxone. So you need to wait until the withdrawals are established, and be particularly aware of those slow release preparations. If people are swallowing slow release preparations, they can be the ones that are a real gotcha. You're sitting around there waiting for the withdrawals to appear. And that's particularly true with Janista, which we know continues to dose people right the way through the bowel, and it's still dosing people with hydromorphone until it exits the bowel, still with some hydromorphone left in the capsule. So you've got to be really, that's a particular one to watch out for. And then you just titrate against their withdrawals. And it's, again, you're doing a sort of quick up and then down to match the expected time profile of their opioid withdrawals. And it also gives you that chance for the first 2-3 days when we're doing the withdrawal management as an inpatient, that first 2-3 days of a Suboxone managed opioid withdrawal looks very similar to the first 3 days of an opioid maintenance induction regime. So you're giving people 3 days to decide, do you want to go up and then down, or do you want to go up and then just keep going up and stay on? And sometimes people are saying, oh, well, actually, I'd never really considered maintenance, but this stuff really works, and yeah, I want to give maintenance a try. So we find that often a decision point for people. It gives them a couple of days of headroom to really think what their long-term plan might be. This is an example of a withdrawal regime with quite wide ranges on it, and we've certainly had some people where we've given them that initial 2 milligram test dose on day 1, and they're snoring half an hour later, and you think, okay, we miscalculated your opioid tolerance here. We probably don't need to do any more than that, and the long half-life of Suboxone will see you wean down over the next 36, 48, 72 hours, and you're not going to need any more. Whereas other folk, sometimes you just find that even on day 1, that 6 mgs isn't enough, and you might need to go up and up and up. But this is a rough idea of a kind of regime that you can start from and then tinker accordingly. And again, with that initial test dose, if in 30 minutes they're significantly worse, then that probably is precipitated withdrawals. If they're about the same, then and still in withdrawal just as bad as they were before, then it probably means they haven't had enough. So teasing those two apart can be a little bit tricky, but usually that's the key, is if they're not significantly worse, you're probably good to go. And if they're much better, then they may not need any more. Things to watch out for. I said opiate withdrawal isn't fatal, unlike alcohol withdrawal. The exception being that, if you've got another medical condition that would be sensitive to electrolyte disturbances. So, if you're on digoxin for your cardiac problems, you're going to be sensitive to potentially your potassium going all over the place because you've got nausea, vomiting and diarrhea. Then that can potentially turn an otherwise unpleasant but non-lethal condition into a dangerous condition. So that's the kind of things to watch out for. Have they got that significant comorbidity? Because of their injecting drug use, have they got other infections? Is there a subacute bacterial endocarditis lurking in the background? Those kind of things. And the other thing to watch out for is, are they taking other substances that they might self-medicate with for their withdrawals, that in combination with what you're giving them could make a dangerous combination. And certainly pregabalin is one that we've seen a lot of that is potentially dangerous if mixed with other substances, and particularly if mixed with opioids. But benzodiazepines and alcohol for self-medicating withdrawals, again, a bit of an issue. So that complex polysubstance use, you might again be looking for. Those are the ones to refer into local AODS or to us. Again, it's those similar things like no safe place. The only other thing is that if you do see precipitated withdrawals, that might provoke a rethink, and then it's time to get advice again from somebody like myself or the local service. Right. I'm going to deal with amphetamines last. Stimulant withdrawals. I mean, I always think stimulants, it's very like tobacco. The physical withdrawals are not too bad, but the cravings and the psychological withdrawals make these some of the most addictive substances out there. I mean, I don't like the sort of, what's the most addictive substance, but it's probably tobacco at the top, closely followed by the souped up, supercharged stimulants of sort of methamphetamine or crack cocaine, which thankfully we don't see a lot of here. So it's mainly psychological. And you're seeing that early withdrawal, the sort of layman's description of stimulants: come in, bouncing off the walls, crash, act like they're nailed to the bed for 36 hours and then wake up toey and hungry. That's the kind of natural history. So you've got that early crash phase where the monoamines have just run out. They've been flogging this increasingly tiring horse of their monoamine system, and then they just run out of monoamines and crash. Fatigued, flat affect, need to sleep, not too much cravings because they're just too busy sleeping, and they'll be irritable every time you wake them up to check their blood pressure, is what we find. Although some of that's nicotine withdrawal as well. Then it moves into that withdrawal phase where the mood tends to be all over the place. They can be happy, sad, acutely suicidal, predominantly irritable. And this is often in the picture, no energy, and this is really when the cravings start to hit. And that's often what's the biggest thing to manage, is that agitation and craving. And then the insomnia kicks in, and the poor concentration, and that can go on for days to weeks. And then it spreads into this months of anhedonia, everything's just grey. It's been technicolor and now it's just grey. They've got that monoamine down-regulated dopamine system, and it's just a real challenge to get. And this is when the cravings are. So getting off is easy, staying off is really hard. So watching when they come in, looking for those signs of acute intoxication, that's part of your assessment. It can be very difficult to do a thorough assessment because their attention span is short and they're overactive, and there's that grandiose and paranoid flavour to their thought processes. Watch out for that acute intoxication with psychotic features. That usually wears off in a few hours, maybe 48 hours, 72 hours at the outside. Beware of that continuing into that stimulant-induced psychotic illness where they're not currently intoxicated, but those psychotic, it can be very difficult to tease that apart sometimes. If somebody's telling you that the drug squad are camped outside the house photographing everybody that's coming and going, it can be difficult to work out if that's delusional reality. If people are worried that they owe some scary people some money and they're out to get them, again, it can be difficult to know whether that's delusional or reality based, but it can persist for up to 6 months and still be stimulant induced. And then you've got the people who've got an underlying psychotic illness which is being destabilized by their stimulant use. And it's difficult to try and tease these three apart, particularly at presentation, although usually time is the thing that just draws this out. The best treatment for stimulants has been and still is counselling based. That's evidence based, it works. For the acute withdrawals, sleep and food are the most psychoactive substances here. We use a few days of diazepam, and we quite like low doses of atypicals, particularly olanzapine, because it's sedating, it stimulates their appetite, they're usually malnourished. And the other thing, of course, is I mentioned they're in this hypodopaminergic state. So you don't want to be giving them something that's going to heavily block the dopamine system, because that's just going to drive the cravings and anhedonia more. Okay. Right. Red flags. Watch out for that suicidal mood crash. Their monoamine deplete and their mood can just drop off a cliff. So keep an eye out for that. Watch out for the psychosis. A little bit of grumbling psychotic. You know, I'm just a little bit self-conscious and worried that people are staring at me. Not too much of a worry, but as soon as they start acting on those, you know, oh, I'm carrying a knife for self-defense, watch out. You know, that's time to be, you know, talking to mental health and AODs. And again, it's the same kind of risks from injecting drug use you've got to worry about, but also the Wernicke-Korsakoff malnutrition stuff to watch out for as well. And a similar sort of thing about, you know, who do you send our way? If it's not working as you'd expect, send them our way, get some advice. Where can you get that advice? Last two slides I want to plug sources of information. For clinicians, this is not for clients or patients to call, this is for clinicians looking for clinician to clinician advice. We've got this ADCAS advice line, the Alcohol and Drug Clinical Advisory Service. It's been up and running since February, and you'll end up talking to somebody like me. Well, in fact, it is me twice this week. So, and similar experts that we can hopefully talk you through any issues that are a problem. My unit is an inpatient unit, so that means it's open 24 hours a day, which means that we have alcohol and drug nurses in the ward 24 hours a day, which is another place that you can get nursing level advice. You know, we can do things like fax you a withdrawal scale or things like that. And again, if you're wanting to refer to us, you've seen somebody that you think might need an inpatient withdrawal, if you can get that assessment done locally, that's definitely going to be better, because the first question we will ask is, what's your aftercare plan? Because as I said at the beginning, withdrawal is not cure. So the first question we will ask is, what's your aftercare plan? And we cover the whole of Queensland, so we don't know what's necessarily available locally. And the ideal for us is somebody goes to their local AOD service and says, you know, I've got a drug or alcohol problem, and they will say, well, yeah, okay, you're going to need a package of care, which is going to involve maybe some counselling. You might need an inpatient withdrawal. We could do you an outpatient withdrawal here, but if you need inpatient, we can send you to the ward, or we can refer you to the ward, but it'll be me that you're seeing when you come out for your follow-up appointment, which is ideal because you've got that continuity of care. Going to see somebody you've already met is a lot easier than walking in fresh to a new service. So making that connection before admission, they're much more likely to follow up with the aftercare after discharge. So that's the ideal, but we know that that's not available everywhere. So we will take referrals direct from GPs and the local NGOs, because we know that AOD's, again, not covering everywhere. So we will take NGO referrals as well. And lastly, this is an information line you can give patients and relatives, carers, and you can get access to, you know, telephone support there. And that website is a useful source of information for clinicians, patients, and carers and partners and family. So now, unfortunately, I've run out of time for questions, but I'm not going anywhere. So if people are wanting to hang around and ask questions, I'm quite happy to do that.
Hi, it's Jeff here. I look after the training program here. We're actually just about to commence work on developing a series of 14 e-learning modules that will be freely accessible to Queensland GPs and other medical practitioners on all aspects of managing patients and outpatient withdrawal. So we are actually about to commence developing that content now. There are, if you go onto the Insight website, which you would have access to access this webinar, there is a bunch of, if you go to the training section, you can get links to our previous webinars, and there might be content in there that might be relevant to you in terms of understanding withdrawal. I would recommend that ADCAS service that Mark just mentioned if you want to discuss a particular outpatient withdrawal that might have some level of complexity to it. The link to our training and webinars past, where all of those, there's recordings of 30 or more kind of webinars there that you can watch of topics that may or may not be of interest to you. But I would contact ADCAS in the meanwhile until we get those kind of sessions up there. We do a nursing withdrawal or a withdrawal kind of management course here as part of the Insight training program. We'll be launching that calendar on Monday. And so if you wanted to subscribe to Insight on the homepage of our website, you can learn about that. And they're offered across the state, but we always offer them every semester here in Brisbane if whoever asks there happens to be a Brisbane person.
Yeah, the other thing I would say is talk to your local AODs, because if you can spare if they're doing outpatient withdrawals and you can spare a day or a half a day, they may well be happy to host somebody to come and just observe. That's another place if you just want to see, the sort of in the grand tradition of see one, do one, teach one. I'm sure, hopefully, starting with the recipes I've given you this evening, I think you can start with the easy ones and refer the difficult ones, and hopefully that's given you some ideas about how to spot the ones that might be difficult that you might want to send on, and perhaps some of the easier ones that you could look at managing yourself. To answer that, we've also had a question about severe psychotic reactions in methamphetamine withdrawal. It's always difficult to answer questions about prevalence when you work in a tertiary referral service, because I only see the severe end of the spectrum. So the vast majority of people who withdraw from methamphetamines do so on their own in the community without treatment. It's the staying off that most of the treatment is directed towards. So severe psychotic reactions definitely happen, and they do happen, sort of emerge in the acute withdrawal phase, as well as I think more commonly occurring during acute intoxication. Particularly there seems to be a sort of kindling process again, where the longer you do it and the more you do it, the bigger the risk that you then go and precipitate. So, I mean, I always talk to the medical students about, give anybody enough amphetamine, they'll eventually go psychotic, but some people take more than others. And most folk will come back relatively quickly if you stop giving it, but not everybody. And it's difficult to know who had a vulnerability that was triggered, and who it's just the amphetamines, or in some cases also cannabis. So it definitely happens. How common it is, I think, really difficult to say, because most of the folk that don't have it, we don't see. In a big tertiary referral hospital like Royal Brisbane that covers an inner metro area with lots of homeless hostel shelters and the like, we do see regularly presentations in our emergency department with that kind of presentation. Several a week, but again, that's a big population with a high prevalence and lots of other risk factors like concomitant psychotic disorders that were already pre-existing. What I would say is then managing it is quite a challenge, but I think you just have to treat acute psychosis like acute psychosis, and then see what emerges. The only thing I would say is I perhaps wouldn't go straight for something that's heavily dopamine blocking, because you're going to drive the anhedonia and the crash harder. But that's probably more for day 2, day 3 and beyond. Day 1, when they come in, often the emergency department's reaching for the droperidol. So when can NGOs refer directly to HADS? Ideally, if you're able to gather enough information, that's really the key. Given that HADS is an inpatient medical unit, the question we're trying to ask ourselves is, how sick are they and how sick are they likely to be? So we're wanting them to be sick enough that they need an inpatient bed, that they're not perhaps suitable, say for example here in Metro Brisbane. If they're not going to need a hospital bed, we might be looking at, say, something like the Salvation Army Moonya, or Fairhaven down on the Gold Coast, or Ozcare. And the other end of the spectrum, are they so medically unwell that they don't need an alcohol and drug bed? They need a general medical bed for their incipient liver failure, or severe hypertension, GI bleed, that kind of thing. So if the NGO is in a position to be able to gather enough information to answer that we can then make a judgment on that, then we'll happily take a referral. The problem tends to be, the sticking point tends to be, what sort of breath alcohol and what pulse, blood pressure, level of withdrawal goes with that breath alcohol. Because if they're blowing 0.1 and showing significant withdrawals, that's telling us important information. Their blood pressure's through the roof, so it may be that you need to work as an NGO in conjunction with a local GP for a physical assessment, so that we can kind of get a better judgment call as to, are they likely to need an inpatient medical bed? And that's really the question. If you can answer that question, we'll take referrals from almost anybody. Other NGO, other inpatient detox. And we have a reciprocal arrangement with Munya, for example, where if somebody pitches up there and looks too sick, they'll flick them across to us. If somebody turns up to our emergency department and their withdrawals are not expected to be too bad, but they need an inpatient stay somewhere, we'll flick them across to Munya. Or if we think we can do this as an outpatient, we might pass them on to locally the ground floor services here at Biala. So I guess that's a long-winded way of saying yes, probably.